Welcome to our series on deep vein thrombosis and pulmonary embolism. We are going to look in this tutorial specifically at the acute management of somebody who's just been diagnosed with a pulmonary embolism or a deep vein thrombosis. And we're going to focus mostly on the initiation of your anticoagulation. Thank you to Dr. Ashraf Mohammed that has helped me with the creation of these slides. So once you've now made your diagnosis, whether it's through ultrasound or your CT PA, there are certain basic blood tests which will largely also be to do with the condition of your patient. But you certainly want to know what the platelets are, so you'll have a full blood count. You need to make sure the renal function is okay. And the liver function and the iron R at baseline is important before we start treatment. The PT and PTT will depend a little bit on the patient on whether that is necessary or not. Of course, with patients who have pulmonary embolism, it's important to have a baseline ECG and X-ray if you haven't done that as part of your diagnostic workup. Not going to spend much time on the acute casualty management for the very unstable patient. Normal rule applies. Obviously, get them onto oxygen, check for, make sure they've got fluids on board, get a line up, give them some analgesia. And usually the unstable patients will be due to a pulmonary embolism. So a DVT on its own is not going to create an acute medical crisis. And then that usually means there has been some embolisms. For both your very massive PEs and your submassive PEs, you definitely want to involve a specialist. And with the massive ones, you might sometimes need to use inotropic support, and there might even be an option of stripping those patients. But for the majority of patients that we see, our focus is going to be anticoagulating these patients. So they're clinically stable, but they have either a deep vein thrombosis or a confirmed pulmonary embolism. And the way you manage the anticoagulation for pulmonary embolism is exactly the same as DVT. So there's this one plan. So anticoagulation always involves two basic things that you will be doing, and you'll start both of those at the same time. And your most important thing is to get heparin on as quickly as possible. And it's possible even to start heparinizing your patients while you're still making a diagnosis. You can always discontinue it if you find that it's not actually a thrombosis. So our preferred drug at the moment is enoxaparin, if you have that available. It can come either as 1.5 milligrams per kilogram subcutaneously once a day, or 1 milligrams per kilogram subcutaneously twice a day. And the 1 milligrams per kilogram BD is probably the preferred route to go for excellent cover. But sometimes for patients, for pragmatic reasons, the 1.5 milligrams once a day might be an option. Watch out if your patient's got renal failure. So if the GFR is under 30, you don't want to go more than 1 milligrams per kilogram per day. And in morbid obesity, you might have to discuss with an expert in terms of your dosing. The other option is the old-fashioned unfractured heparin, and in the EML, there are some tables to make the dosing easier. So for example, you can start off, there's a loading dose table, and you start with 333 milligrams per kilogram, and then there's a twice-a-day dose at 250 units per kilogram, and the tables makes it very easy to prescribe. Again, in obese patients or patients with GFRs under 30, you can actually use your PTT to monitor whether you have got enough heparin on board. And the way you do that is you actually check that PTT 4 hours after you've given the dose, and you aim to give it about 1.5 to 2 times the upper limit of normal. Now, on the same day that you start your heparin, you're also going to start your warfarin, because it's going to take a few days for your iron R to actually get onto track. And actually, in those first 2-3 days of starting warfarin, there's actually a higher risk of thrombosis if you were not covered by heparin. So it's very important that these two happen at the same time. And for the vast majority of patients, you're going to aim for an INR of between 2 or 3. There are some cardiac patients, but a cardiologist will make the decision that might aim for a slightly higher INR, and those patients will usually be under specialist care. So again, your EML gives you a very nice step-by-step way of doing this. Day one, we usually start with 5 milligrams on warfarin, so on that same day that you've started your heparin. If you have somebody where you're concerned, if they're very, very thin, for example, or you're a little bit concerned about what that baseline INR already is, you can use a lower dose. And then 2 to 3 days after you've started your warfarin, you're going to check that INR again, and then you can see there's a nice sliding scale. So you can use your sliding scale to then adjust your warfarin depending on what the INR is. And then 2 to 3 days later, you will check again. So usually within that first week, you're going to check the INR twice, and you're going to adjust the dose of the warfarin accordingly. And then they have this little table regarding the frequency of INR. So basically, once your INR, you've been doing it every 2 or 3 days. If it looks like it's nicely on track, you'll do it every week. If it's still nicely on track, you'll do it 2 weeks later. If it's still nicely on track, you'll do it 4 weeks later. So this gives you sort of a nice structure of how often to do that INR until you can confidently say that on this particular dose, the INR seems to be controlled between 2 and 3. Just a word about heparin-induced thrombocytopenia. It's a rather strange condition. It's an immune-mediated drug reaction against the heparin, and you actually have to have a genetic predisposition for this to happen. It only happens in about 1 to 5% of patients. It's quite uncommon, and we see it more in the heparin than we do in the enoxaparin patients. The strange thing with the clinical presentation is that you would have low platelets, but as well as thrombosis. So you actually might even develop a new DVT. And the reason for this is that the condition is actually caused by these positive antibodies against the heparin, and these antibodies creates increased coagulation in the body. So you want to think about this if your platelets drops within 50% within 5 to 10 days after starting the heparin. So that means we do need to keep an eye on our full blood count and our platelets. And patients can present, for example, with chills, fever, shortness of breath. So a patient is suddenly getting unwell while they're on that heparin. You want to see what is going on. And basically you want to stop all heparin immediately upon suspicion of HIT. And you're going to be discussing these patients with a specialist. As it happens, usually quite often patients within a week or so is stable on the INR, and then we can usually stop the heparin. So quite often we don't get to the point where we see patients developing HIT. In our next presentation, we're going to talk more about how we now adjust that INR for somebody who is a chronic patient on warfarin, and how we do the adjustments after that.